Yes, so we are holding our first tumor boards for this year. Thank you everybody for attending. We thank you for your time. I would like to introduce Dr. Rafiq Al-Biblawi, board certified internal medicine physician, and who will be accompanying us through the evening today along with our respected panelists and presenters. Thank you.
Thank you, everyone. Just a brief introduction. My name is Rafi. I'm originally from Cairo University, Egypt, and did my medicine training over here in the US. Thank you for being a part of this tumor board. Let me introduce quickly our panelists here: Dr. Mohammed Higazi, our ABCDE director and associate professor, section chief of the bone marrow transplant at the University of Louisville. Dr. Robert Emmons, he's a professor of medicine and bone marrow transplant as well at University of Louisville. Dr. Sameh Gaballah, he's the associate professor at Department of Malignant Hematology and Bone Marrow Transplant at Moffitt Cancer Center. I think Dr. Al-Kawaz is here as well. Dr. Mustafa Al-Kawaz, he's the assistant professor of pathology and lab medicine at University of Louisville. And from Egypt, we have as well Dr. Muhammad Awad. He's a professor of medical oncology and bone marrow transplant at Mansoura University. Dr. Manar Hamid, assistant lecturer of oncology and at Faculty of Medicine at Mansoura as well. And last but not least, I think we have our presenter today, Dr. Dina Abdel Ghaffar, which is a resident of medical oncology at Mansoura as well. I think without further ado, we can go ahead and start. Dr. Abdel Ghaffar, if you want to go ahead and...
Perfect, but Manar, Dr. Manar now is a lecturer.
Oh, great. Sorry, my bad. Congratulations.
Yeah.
We have also associate professor of medical oncology and hematology, Professor Dr. Ziad Amara, joining us from Jeddah.
Great.
Welcome, Dr. Ziad.
And the professor,
everybody. Thank you, Dr. Mohammed.
Professor of flow cytometry, she's here with us. Welcome, Dr. Dalia, and welcome everybody.
Thanks,
Okay,
Manar. It's nice to join you today.
It's
Dina? Yeah.
Good evening, everybody. At the beginning, I'd like to welcome our honorable guests. I'd like to introduce myself. I'm Dina Mohammed Abdel Ghaffar, resident of Medical Oncology Center, Mansoura University. It gives me a great pleasure to present my study case today. A 21-year-old male patient, case of TLL. First presentation was chest pain since December 2022. Medical and family history-free, surgical history, strabismus surgery, single, non-smoker, virology negative. Post-contrast CT chest on December 2022 show large enhancing anterior and superior mediastinal soft tissue mass extending to root of the neck, encasing major mediastinal vessels, inseparable from anterior and superior pericardium, and continuous with left parahilar perivascular soft tissue mass extending along lower artery branch in left lower lung loop. It measures 7 by 13 by 18 centimeter. Another similar mass seen in apical segment of right lower lung loop, continuous with previously described mass, diffuse right pleural thickening with multiple bilateral cervical and axillary lymph node. Biopsy was taken from a large mediastinal mass outside our center and revised when patient presented to us, showed malignant round cell tumor consistent with non-Hodgkin lymphoma, T acute lymphoblastic lymphoma / leukemia, CD3 and TDT positive reaction in a typical cell, and CKCD20 NKX2.2 negative reaction. CBC at presentation showed a total leukocytic count 51 with absolute lymphocytosis 37, hemoglobin 13.9, and platelets thrombocytopenia 39. Bone marrow aspirates show hypercellular with blast cell 85%, and bone marrow biopsy non-representative biopsy unfit for diagnosis. Smear banking done and scrotal ultrasound normal. echo syndrome, circumferential pericardial effusion with no sign of tamponade, ejection fraction 69%, received pre-phase, then start course 1 hyper-CPAD in February 2023, and plus first triple intrathecal and CSF analysis was no infiltration. First re-evaluation after course 1 hyper-CPAD, bone marrow normocellular and plus 2%. Bone marrow biopsy normocellular about 80% cellularity with no detected increase in the blast cell. CT chest show regression of mediastinal mass, measure 3.4 centimeter in maximum diameter, no pleural thickening or effusion. Patient continued to course 8 hyper-CPAD last in August 2023 and PET CT re-evaluation done after course 8 hyper-CPAD in 1st October 2023 with reference liver SUV 2.5 and mediastinum SUV 1.8. Extranodal show metabolic active focal subcentimetric right paraspinal soft tissue lesion at level of D7 achieving SUV max 3.5. Metabolic active thin sheet-like chest wall soft tissue thickening, pleural base achieving SUV max 4 with maximum thickening 9 mm, Deauville 4. Biopsy from chest wall mass was taken and pathology non-representative biopsy format of skeletal muscle and fibrous tissue. The decision was to start BUM protocol maintenance, and patient already started a first cycle, vincristine, prednisolone, and 6-mercaptopurine amisotrexate. CSF after 1 week from first cycle show heavy infiltration by frequent blast cell, and the flow in CSF show T-cell markers. MRI and whole spine normal, and marrow re-evaluation bone marrow aspirate normocellular plus 2%. Patients received salvage flag, fludarabine 30 mg per meter square, IV infusion from D1 to D5, and citrabine 2 gram per meter square IV infusion from D1 to D5, plus growth factor from D5. On 21st November 2023, plus triple intrathecal twice weekly. First CSF flow after first triple intrathecal show atypical immature T-cell detected 8% in CSF sample, and after that free. Patient continue in triple intrathecal twice weekly 1 month later, and after that he received craniospinal irradiation 24 gray on 12 fraction. Then started to work bone marrow transplant workup, HLA matching with his sister, who is 14-year-old female and who fully matched. And at this point, I would like to mention that he has only one brother. His age was 20-year-old, but he wasn't available as he was travel abroad and he couldn't done HLA matching with him. During bone marrow admission, patient done non-contrast CT chest and showed newly developed right side basal pleural soft tissue-like thickening of maximum thickening 2 centimeter. Biopsy was taken and showed T-cell lymphomatous infiltration. Then patient received phlegm, fludarabine from D1 to D5, plus noventrone 7 mg per meter square from D1 to D3, plus growth factor from D6, plus triple intrathecal. CSF analysis free. After phlegm, PET CT re-evaluation done in March 2024 and free. PET CT was free, Deauville 1. Then patient proceed to bone marrow transplant, conditioning busulfan 1 mg per kg every 6 hours from D-5 to D-2, and cyclophosphamide 30 milligram per kg from the -10 to -7. D0 was 7th April 2024. GVHD prophylaxis cyclosporin plus methotrexate. Patient complicated by hemorrhagic cystitis from cyclophosphamide. Engraftment occurring at D+13. First reevaluation after bone marrow transplant was bone marrow aspirate at May 2024, normocellular 1% blast cell, and bone marrow biopsy was hypocellular bone marrow 20% cellularity with no abnormal deposit. Immunosuppressive cyclosporin stopped after 3 months. At D+3 months and 16 days, liver function test started to increase to false or more, with no other signs like chest or GI scan, mouse, and eye manifestation. As ALT 142 from upper normal limit 65. And AST 129 from upper normal limit 37, normal bilirubin elevated alkaline phosphatase 156 from upper normal 128, CMV-PCR negative and pelvic abdominal ultrasound free. Patient started steroid 20 milligram BID at D plus 115. The liver enzymes continued to rise, so steroid dose escalated to 40 milligram BID at D plus 129. Then at D plus 122, patients start to complain of blurring of vision. Ophthalmology consult done. Patient had myopia and eye glaucoma, early complicated post-subcapsular cataract due to steroid therapy. First triple intrathecal given at August at the +4 months and 14 days, and flew done on CSF. Show both cellular limited panel was done. 49% of T cells. Flow consistent with CNS involvement with TLL. Patient complete workup. CT chest with contrast done. Show newly developed few left pleural thickening reaching up to 1.4 centimeters, suspicious, and well-defined right paraspinal mass with possible intraspinal extension 4 by 3 centimeters. Bone marrow reevaluation done again and aspirate free 1% blast and bone marrow biopsy, hypocellular bone marrow with no detected atypical cells, karyotyping 46XX, DLI done, and patient receiving from his sister bag 300 milli equal to 9 by 10 power of 6 kilogram with twice weekly triple intrathecal steroid stop. After DLI, after 1 week from DLI, patient presented with severe productive cough, high-grade fever, and desaturation 88 diarrhea 5 times, and mucositis. Lab show total CBC, total leukocytic count 13, neutrophil 11, hemoglobin 14.5, and platelet 208, total bilirubin 2.5, and liver enzymes normal, serum albumin normal, serum borocal high 1.5, and CRP positive, culture no growth. CT chest at presentation after the 1 week from DLI. Chest consult done with differential diagnosis infection, GVHD infiltration, fibrotic interstitial lung disease. Recommendation to start good coverage antibiotic and antiviral and steroids. Patient started good coverage antibiotic and antiviral and steroids. Mucositis and diarrhea improved, bilirubin returned to normal, and chest symptom improved. Follow-up CT chest show regression. and this is the CT chest after started treatment. On follow-up CT chest, newly developed left lateral costal pleural thickening reaching 1 centimeter opposite left sex rib. Progression of right paraspinal lesions, infraforaminal extension now reaching 2 by 4 centimeter. Re-evaluation done, complete re-evaluation, bone marrow normal, plus cell 1%, and bone marrow biopsy hypocellular, cellularity percent, negative for malignant. Patient complete triple intrathecal twice weekly and reach 2 tenths. CSF analysis through. Patient received 18 sessions radiotherapy on paraspinal mace, nuchimerism done, and patient karyotyping 46XX. Stop destroyed gradual at D plus 7 months and 19 days. Follow-up MRI after palliative radiotherapy on paraspinal soft tissue mass show regression as regards size and extension of right paraspinal soft tissue mass with intraforaminal extension. Now it's seen localized to level of D10 and 11 disc. Measures 7 millimeter in maximum thickening. At last, at D plus 9 months and 1 day. Lab ALT 335 and AST 368, serum bilirubin elevated to 2.8, and patient stopped steroids 1 month ago from this lab. Serum albumin normal and CBC total leukocytic count 3.8. Neutrophil 1.2 and hemoglobin 12.6 and platelet 260. Discussion points about what's the best management of this patient.
Thank you very much, Dr. Dina. I'm guessing there's not much pathology to be reviewed.
دكتور محمد السلام عليكم.
وعليكم السلام دكتور معبد، ازي الصحة، ازي صحتك؟ الحمد لله تمام.
الحمد لله. Just I have an update for the liver function test for this patient because he was in a visit this morning to our clinic. The liver enzyme is still rising, so the last estimate 495, and the AST 507. And bilirubin is still high, and the CBC is still okay. That's all.
Thank you for the update. I'm just writing down.
Okay, the pathology is, we are sure about it. There was no need to review it again.
Okay, and there was no pathology from the lung or the liver?
No.
Got it.
No.
All right. And what's the status of the disease itself as most recent? Because the patient had a CNS involvement about 4 months, got intrathecal chemo, and there was the enlarging paraspinal mass, and that got radiated. Any evidence of disease most recently, just so I can recap?
Well, last CT showed regression of the paraspinal mass. It is now 7 millimeter, and the last CSF analysis is free.
Okay. Now the questions are this. Just before we get to the discussion points, just a quick pointer in things that maybe we do it a little different. FLAG and CLAG as a primed regimen, we typically start the growth factor before we start the chemotherapy. I saw in the description of the case that the GCSF was started at the end of chemo. When we prime the regimen, we use it, 1 day before we start fludarabine, 1 day before starting cladribine. there's nothing wrong in
Yes,
what happened.
we do that. Yes, we start the cross factor with the flag regimen, with the flag regime, to prime the bone marrow before starting the regime. But for the flam, we start on day 6.
Got it.
Yes. When we add novantron, it is a flam, not flag. We start on day 6. But for the flab, we start to prime before the regime. Yes.
Got it. But in this case, fortunately, the patient eventually did clear the disease with CLAG and went on to transplant. And it looks like we dealt initially with a case of liver GVHD that got better, then lung. That the images look like it gotten better as well, based on the CT, the one slice of CT that we saw. It improved somewhat, but the liver is the problem now, right?
Right. But I have something, Coach Dr. Muhammad, for what happened to this patient after the DLI. So what do you think to be the pathology that happened with the lung?
And to set the scene, Dr. Muhammad, it is not a typical DLI. We have just given him fresh blood from his sister, right? Am I right?
Yeah.
So
it's not a typical DLI.
What's the dose again of the CD4?
We didn't calculate the CD4, Muhammad, just because we estimated the lymphocyte content of this 300 ml of the donor blood.
It was 9 in 10 power of 6.
Oh, that's actually a small dose. That's a small dose. So that's 0.09 times 10 to the power of 8 from a matched related sibling. So that's a very small dose, but nevertheless, the patient did develop what seems to be, if it's not infectious, that it is GVHD.
It was a GVH, yes. It was a GVH. The patient improved on steroids, yes. It was a GVH.
Right.
Well, how long after this DLI did the lung syndrome start?
Just 7 days, it seems, is the
1 week.
symptom.
1 week.
Yeah.
So there was no symptoms sooner than that. The reason I ask is because this was peripheral blood collected by the donor. Trally is something that can sometimes happen complicating infusions from the peripheral blood, nonspecific antibodies to white cells, and that typically occurs within a short period of time, but there's a delayed form of Trally as well. That is also responsive to steroids and isn't related to the classic physiology of graft versus host disease.
Yes, but we did reduce diarrhea and mucositis as well.
I'm sorry, say one more time?
Would the Trally produce diarrhea and mucositis?
So it seems like they developed mucositis and diarrhea along with respiratory failure, so they're thinking it's more of GI involvement. How bad was the diarrhea? Did you measure the stool output?
It was grade 2, 5 times per day. I don't know if they measured it or no, but it was grade 2.
Grade 2. Okay.
There's such a thing as hyperacute GVHD, but it's very rare, especially with related donor transplants that are fully matched like this. So this was a fairly short period of time after the DLI to develop such serious side effects. Typically, especially with the dose that has been mentioned, it would take 4 to 6 weeks to see the onset of this, unless it was, again, hyperacute. But again, hyperacute is more commonly seen in mismatched transplants than fully related donor transplants.
Yes, the dose is quite small. However, we have stopped all the immunosuppressant because he was in relapse.
Right. Was
So
there any bronchoscopy done to evaluate these infiltrates in this immunocompromised patient, or sputum collected anywhere along the way?
The sputum culture was done and it showed no growth, but I don't think that he did bronchoscopy or lavage.
And I know that he's had intermittent problems with CMV. CMV can also cause the syndrome that you've described. How high was the CMV in the blood at this time?
We did PCR and it was negative. No, it was not CMV.
Yeah.
Was that EBV or CMV? I'm sorry.
CMV PCR was negative.
Thank you.
Yes. So, and right now, Dr. Nasser, the pulmonary function and the respiratory status is back to baseline, normal?
Yeah, it's normal.
Okay. So now the main problem here is the liver now, is the liver hepatic concern for GVHD. So do you do liver biopsies, and do you have the pathology ability to evaluate the GVHD of the liver on biopsy?
No, we usually do not evaluate GVHD by biopsy. We rely on clinical scenario rather than biopsy.
Can you tell me where the radiation port for the paraspinal mass was? Did it involve the liver in terms of radiation dose?
Well,
no,
we don't
don't think
know,
so
actually.
because it is directly to the the mass at the lumbosacral area, I think.
And
Oh,
the
so the
mass
mass
at
was
G10
down.
and 11, so it's like in the thoracic 10 and 11, so I guess
10 and 11 is the mass.
I don't know. It may include the liver.
So the liver was not irradiated, is that correct?
Actually, we don't know because we are not a radiation oncologist. So
I see.
But
Certainly
now we have the 3D technique. I believe the liver will not be injured by radiotherapy. We have seen a lot of cases irradiated for spinal lesion, and we have never seen even one case of liver injury. It is not just a 2D irradiation, it is a well-planned 3D irradiation. I believe it was not an irradiation injury.
Hi, this is Samah Kaballo. So, I think, I mean, there's like a few things that could be going on. Obviously, the patient had, my understanding is the patient had some relapse post-allo, and then it was controlled, correct?
Correct.
yes,
Yeah. So there's always the possibility that, the patient has relapse disease with, liver involvement. I mean, that's obviously one on the differential. The other thing is, it could be GVHD. It could be infectious. So I don't know if other extensive, viral testing. I mean, I've seen like a post-mortem case before where, it turned out to be disseminated adenovirus. I've seen disseminated herpes. Without anything, it was just like hepatic failure. So I probably would just start with like a liver biopsy. I mean, if there's disease there, you're going to see it. If it's infectious, you might see, viral inclusion bodies. You could do some staining. And definitely I would try to get maybe PCRs in the blood for other viral etiology. But I think, probably maybe a liver biopsy would be the place to start.
the thing
To
is,
what
he's
extent
also
it will be
he
safe,
relapsed
Dr.
really
Mustafa?
rapidly.
To what
He
extent it
relapsed
will be safe,
quickly.
the liver biopsy in such situation? Dr. Muhammad, I'm talking about the safety of the liver biopsy.
I mean, you could do it as transjugular if there's issues with platelet count.
We always discuss this amongst ourselves because of the potential injury from liver biopsy, but transjugular that intervention radiology help us with is typically the safest way in getting these liver biopsies without the risk of bleeding.
Yeah.
Or minimizing the risk of bleeding. But if we focus on that, let's say that if the pathology shows GVHD, because I see here there's quite a bit of questions regarding GVHD, the initial treatment for the GVHD of the liver that was 3 months post-transplant was purely steroid, correct? When the patient had elevation, AST, ALT, and ALK phos, but normal bili at that time?
Yes.
Yeah, and then we tapered the patient slowly off of the steroids, and we had the CNS involvement about a month after the liver GVH, and the patient has been off steroid for about a month prior to the DLI, correct? I'm just trying to get the timeline in my head straight. So steroids hasn't been tried yet on the liver, or is the patient currently actively on steroids?
No,
I believe we have escalated the dose today, Dr. Muhammad Nasr. He was in a small dose steroid. We have
no,
we have escalated
no, he is
today,
off
right?
steroid. Dr. Muhammad is currently is off steroids. We stopped the steroid. Yeah.
Okay.
Off steroids.
Mm-hmm.
And the LFTs is rising in the past month or so, correct?
Yes.
Mm-hmm.
Correct, because we are aiming to, we hope that these changes are related to the GVL, the effect solved. We didn't want to weaken this effect or something like that.
Yeah, to get the benefit from the DLI, but right now it seems like the liver is suffering. The bilirubin, how high is the bilirubin today, Dr. Nasr?
Actually, we didn't check this because we don't have kits for the bilirubin.
Okay, but the LFTs were elevated, the AST and LFT.
Yeah.
Those are over 400 or 500 is what I heard. Something like that.
Yes, exactly. Yeah.
Yeah. And also ALK-Phos is elevated, right? Because we do always believe that ALK-Phos, represents before bilirubin starts going up. But typically, if it's been a month and the bilirubin is still normal, it's an interesting.
The last bilirubin reading at 15 this month, it was 2.6, so it is elevated.
2.6, got it.
Yeah.
Elevated at 2.6. Okay. So, Dr. Gawalla, in terms of if we kind of hypothetically make the case that we have the liver biopsied and there is no evidence of disease on the liver, just like the CSF and the bone marrow, and that mass in the back is regressing, the patient has seen steroids before, but now is not on it, and the pathology comes back GVHD. What would your recommendation be in that regard?
Yeah, so as you know, I've been away from transplant for a while, but I probably would start with 2 per kg, steroids.
Right.
Try to get it under control. I mean, you could do other things. You could try, like a Jakafi. I don't know if you want to try like a ibrutinib or one of the BTK inhibitors. But I don't know. I mean, we don't even think this is steroid refractory GVHD, right? We haven't done.
Not yet. Haven't been proven to.
Yeah, exactly. So if we rule out infectious etiology and we don't think this is disease, and obviously, obviously you need like an ultrasound, to look for. This is not like a VOD, right? There's no weight gain. There's nothing else going on. If they've done like the ultrasound with Dopplers.
He is losing weight. He is actually losing weight. I don't believe this is VOD. Yes.
Oh, okay. Yeah, I mean, if you rule out infectious things and disease, I think you could, you could try 2 milligram per kilo steroids, and if that doesn't work, then we could talk about these other options. But at this point, we haven't even tried the steroids.
Yeah, Dr. Emmons, any other thoughts in terms of workup and investigation that you would like to add here?
I certainly agree with liver biopsy if possible, because there have been recent publications that have shown in over 50% of cases that the underlying etiology was not thought of by the clinicians before the liver biopsy was obtained. Very important point in terms of the overall workup here. Furthermore, the blind use of steroids in a patient like this sorry, the blind use of steroids in a patient like this who's had multiply relapsed, difficult to treat and probably less GVH responsive ALL is problematic because you're playing with fire in terms of yet another relapse for this patient who's had peripheral relapse, central relapse, and paraspinal relapse. So I think I would be very, very careful with regard to steroid or other immunosuppressives, though if GVH proved to be the case, then I agree that a drug like Jakafi might be a better choice than steroids in this case, or consideration of things if possible like photopheresis or other relatively less immunosuppressive ways of trying to control what we think is an immunologic response here.
So, Dr. Awad, is photopheresis available?
No, not available.
Not available. Got it.
Yeah, but photopheresis, do we think it's going to work
for,
with, like,
for
liver
Jakafi,
GVHD?
we have Jakafi. It can be reimbursed for him. Yes, we do have Jakafi.
Yeah, I honestly, I haven't had success with photopheresis for liver GVH. We do it out of disparity, but it we haven't had much luck in terms of its benefits. Jakafi and Rezurock is where we typically would go. The ROCK2 inhibitor, and typically the steroids, as Dr. Gaballa mentioned, 2 milligram per kg. And in my mind, this is quite an inflamed liver. The damage might be long lasting if we don't get to it in a faster fashion. Jakafi's response is not very quick either. So I worry if we don't use steroids that we wait a long while for the GVH to respond to Jakafi or whatever is the other target that we use, ibrutinib or Rezurock. Ibrutinib has fallen out of favor in our use. But I would, the 2 milligram per kg here is more of a test as much as it is as a study, a treatment. Because if this indeed is GVHD and it's not infectious, it is going to work quite rather fast. And in this specific patient, the patient did respond to steroids early on. So we have evidence that the graft here is responsive in its GVHD to steroids in the past. Something that we are getting ourselves more and more familiar with here is blood tests to assess whether steroid is going to work or not. These are Eurofin. There's a lab here that you can send them a blood specimen right before you start GVHD therapy, and it tells you whether the patient is likely to respond to steroids or not. And then you are ready to employ second or third line agents because
what do they measure, Dr. Mohammed? How do they know?
They have two tests. It's ST2 and the other one starts with a G. I forgot it. But I'll send you their the data that they have. But they basically come up with 3 different results, putting in an Ann Arbor 1, 2, or 3, and the severity goes higher as the number goes higher. So the more refractory the GVHD is likely to be to steroids, it comes as a 3, but a 1 is more of like you're possibly to respond. The problem is that you have to send the test to the company has to run it and come back to you. And sometimes you're losing time there, but at least you're getting something that tells you don't be heavily wed to steroids if steroids are unlikely to respond based on these blood tests. The problem here in the United States, these tests are not reimbursable by insurance. So it's a cost that we have to keep, and we're trying to get it more and more in our practice. So in our clinical practice, it's not as routinely done in our center. I'm talking, I'm not sure about the other centers, but in our center, we're not routinely doing it as much as we think about it in difficult cases. But in my mind, 2 milligrams per kg of steroids here would be a test as much as it is a treatment for this patient. I know we're worried of the relapse, but if this patient's liver, like the bilirubin is 2.6 most recently, if it becomes 16 in a couple of weeks, then we are in a very bad place and the patient is unlikely to survive the liver GVHD. So that's the problem here, is what's more harmful. And that's why the biopsy can clarify this picture for us. If it is indeed non-infectious, non-viral, non-disease, then you feel strongly that you can hit with high dose of steroids. And yes, you are buying a potential risk, and I understand totally what Dr. Emmons is mentioning, the risk of relapse with high dose of steroids, but also you want to see how much are you benefiting this patient. You will see it much faster with the steroids than with the others. This patient is now gotten the DLI happened about a few months ago now, 2 or 3 months maybe ago.
Yeah.
So we are looking at a potential that the benefit from the DLI in of itself is kind of on the downtrend. And honestly, I'm not a big believer that DLI works in patients who have ALL, because as I'm sure when we're trained, is graft versus leukemia effect in ALL is very weak to begin with, and the heavier the approach in terms of achieving remission, which here was CLAG, is what got this patient into remission, and the unfortunate relapse that he has had has been recurring, which is a big concern, that the patient will still relapse. That's definitely not off the table. But with ALT, AST in the 500s, bilirubin is 2, alk-phos is up. I think we need to investigate this liver. And again, you need a pathologist who is familiar with liver GVHD. And Dr. Alkawaz he's with us today. I'm sorry, I know we haven't had a review pathology, but Dr. Alkawaz, when we discuss these cases, even in the United States, you have certain centers and certain labs that you send them to. Those. Any comments, Dr. Alkawaz, on this?
Not really. Again, it has not everybody. Liver biopsies are particularly they're sort of in their own niche, and so I agree with your comments. It needs to be somebody who understands medical liver very well.
Right. So I'm not sure if that would be still within University of Mansoura, or does it go to another center in the country or elsewhere?
Dr. Muhammad, in the case of reviews of the patient to do the liver biopsy.
I'm sorry, the patient.
If the patient refused the liver. Yeah.
Then I think I don't have anything else but to treat.
Therapeutic test with the steroids and observe.
Right. Right. If they refuse, they just need to understand that we might be taking a risk with the high dose steroids, the risk of relapse, the risk of infection becoming worse. But yes, I think so. Dr. Emmons?
Yeah, 3 other questions. Was this an ABO matched or incompatible transplant?
Gina, do you have the data?
The blood type on the donor versus recipient?
This question again.
Gina, do you have?
I ask regarding the bilirubin as to whether there may be a component of hemolysis adding to that and potentially increasing the relative worry. Next, are there any medications like azole antibiotics or anti-cholesterol medicines or anything else that might cause liver inflammation in this patient?
No, currently the patient is on liver support, that's all. No medications.
I see. So no other medicines. Gotcha. And the patient's already off antifungal therapy because he's post treatment. Is that correct? Post immunosuppressant. So.
No, they stopped. Yes, I stopped the antifungal.
Patient now on liver support only. Stop the steroid.
What is liver support? What does that mean? What is liver support?
Orthodeoxycholic acid.
Yeah.
Oh, orthodiol. Got it. Orthodiol. Okay. Got it. Excellent questions. Just out of curiosity, when do you usually discontinue antifungals post-transplant?
we continue all through the GVH so long we are prescribing immunosuppressant, but for this patient in particular, and due to elevated liver enzymes, we decided to stop the antifungal early as a test. We thought it might be responsible for the toxicity. So we have stopped the antifungal and we didn't start it yet again.
So, Dr. Awad, are you commenting about the discontinuation early with the very first liver GVH that the patient had in 3 months post-allo?
Yes.
The first time?
Yeah. When the
Got it.
liver enzymes started to rise, we stopped fluconazole.
Okay. All right. These are good points because patients can develop some of these markers. These would be easier to fix than GVHD of the liver if it's a hemolytic process or if it's medications induced. But if the patient is refusing, or if the procedure is deemed to be more a higher risk, or if the pathology, the pathologist who is specialized in reading liver is not available, I think it would be a therapeutic test to use high-dose steroids, of course, with the patient's understanding that this is likely, that this is increasing the risk of the patient's relapse with the disease. Unfortunately, the odds of relapse are high whether we used steroids or not because of the way it's real. Just to confirm, did we biopsy the paraspinal mass to prove that this was disease?
Yes.
Okay.
Yes, it was biopsy.
Sorry, I missed that part. Yes, so it was disease proven. Got it. Yeah. So if that's the case, the risk of relapse is extremely high. I totally understand. But also the risk of liver failure and that in itself causing the patients to die is high. And we don't want to wait any further to initiate therapy for his acute GVHD. What was used to correct his respiratory, these impressive lung function, images though? So what did we use to fix the severe respiratory failure T plus day 7 post DLI?
We covered everything. We used molnupiravir, which is an antiviral, and we used steroids and broad coverage antibiotics.
So what was the steroids used?
60 milligram. What do you use, Dina? Prednisolone? Or
Yes.
1 mg per kg.
1 mg per kg. Okay. So 1 mg per kg, that was used 7 days after the infusion of DLI and discontinued how long after that? Like tapered off or stopped?
Tapered gradually.
Tapered for over a month?
Yes, approximately over 1 month. Yeah.
Because and then about a month after that is where the liver started having the GVH.
He relapsed after that.
Yeah, the enlarging mass happened about a month after the DLI.
Yeah.
I'm writing down the timeline myself so I can understand it better. But yeah, based on all this, the risk of relapse is extremely high. And I think if the patient is going to worry about or refuse the liver biopsy and high-dose steroids, giving the risk of relapse, maybe then, like Dr. Gaballa and Dr. Emmons mentioned, the use of Jakafi, the use of Rezurock is something that can be considered there. Just remember that Jakafi itself we need to watch the liver as you start Jakafi to make sure that the Jakafi itself doesn't cause the numbers to go up higher in the first few days. So you're starting it at a 5 milligram twice a day for a few days before you go up to 10 milligrams twice a day. And in that sense, the picture can become a little muddy.
One of our team reported that the patient was B positive and the donor was B negative. Dr. Emmons has asked that question.
Mismatch.
Thank you for that.
Oh, yeah, I mean, I'm sorry, did we Was this patient like a hepatitis B checked ever? Like hepatitis B, hepatitis C, just the simple
Oh,
stuff?
yes,
No,
yes,
no,
we
it
have.
was negative. We do the test and it was negative. So what do we do when he relapses again?
I believe
TALL.
I believe he is an
Yeah, not much.
I don't know if we're gonna have any good. There is, what is the
second transplant maybe.
yeah, and then there is the drug that we're now pediatric is using it in the frontline setting in their ALL,
Nelarabine or what?
Larabine, but by itself is not a great drug. There's some data using venetoclax and hypomethylating agents as a salvage therapy in those patients. But it is a bad situation as the patient relapse, and I totally understand why systemic therapy hasn't yet been used here, because we're trying to minimize the toxicity as much as possible in hopes for immune reconstitution. But now you have both problems. Maybe the disease is not as much as the GVHD potential right now, but the disease is likely what's going to come back. That's the unfortunate reality.
Okay, Dr. Mohammed, so what about if we start the steroids as 1 mg per kg?
Yeah.
Plus Jakafi at the same time?
Yeah. We discussed this. It's funny because I was discussing this with Dr. Emmons in a M&M that we had just a couple weeks ago. We believe we either are, as they say, you go big or go home with the steroids. You want to make a difference, because what if you don't see a response after being on the 1 mg per kg for a week? So the patient has been on steroids for a week or two and not a whole lot of response. Are we going to then push the dose up to 2 milligrams and then wait a little longer to see if things are working or not? That's the barrier there. So we either use it in full and drop it when we don't think it's working. That's the other end of the problem, is we start the steroids and then we feel like we are going backwards if we stop it, even when we add Jakafi or Rezurock or ibrutinib or Velcade or photophoresis and all. I don't know. I sensed the concern from Dr. Emmons about the steroids, so he might be more open to the 1 milligram per kg than myself. But Dr. Emmons, what do you think?
So I think I agree with Mo in terms of go big or go home. My point would be that the duration of steroids is the more issue here than the dose. So if you start at a good dose, like 2 per kilo, and you've established there's a response, you want to try to rapidly wean down that dose to the minimal necessary and not continue that for more than, a week or two if you can avoid it. That's the more the duration of steroids is just as toxic as the dose of steroids. So I would use a short course of higher dose to establish whether there's a response, and if there is, try to get a rapid taper, and potentially during that rapid taper, since you seem to be then proving that it is GVH, add in Jakafi to see if it can be used as a steroid-sparing agent.
Like a sequential approach. You get it, and then you use it to get the patient off. That's another way.
Okay, but the problem it will be the problem. The liver condition will be related to the infiltration, and in such a case, it will be also responsive to steroids.
That's correct. That's why the real right answer is to get a liver biopsy. You're sort of, feeling around in the dark, as I mentioned, that, publication that showed that essentially 50% of the time, the clinicians were unaware of what the true pathology was until the liver biopsy was done. I think in cases like this, where there are many possible contributors, infectious disease, graft versus host disease, perhaps others, You won't know without a biopsy, and it's a critical decision-making tool at this point. Does your hospital do transjugular biopsies?
No, actually no.
I see. And are the patient's coagulation profile and platelet count such that it would significantly increase the risk of liver biopsy?
But there is right now
INR is one.
is
INR is normal,
yeah.
and the platelet count is normal.
Then I would have another discussion with the patient about the relative benefit and serious consideration of a liver biopsy, given normal coags, normal platelets. The relative morbidity and mortality certainly isn't zero, but is less than many of these patients who have coincident, very bad coagulation profile and low platelets as well. So given that the risk of steroids is substantial for relapse, having a greater understanding of what's happening in the liver is a critical issue in terms of the survival of this patient.
Okay.
Sounds very reasonable. Any other comments from the team?
No.
Right.
Okay. Okay. So
we'll just mention this because it's something that we've talked about a lot here. That the TALL is not one disease, but a family of diseases. It's been very difficult to tease out the relative differences between these different kinds of TALL. There are now emerging PCR techniques to get a better handle on that. I will put a publication in the chat that sort of goes over some of this data most recently for everybody to review. So there may be in the future a potential to not necessarily be aggressive with some patients. Obviously, this patient has aggressive TALL, but there are patients who have seemingly lesser aggressive TALL, and we may eventually be able to stratify these patients. I don't know if Dr. Alkawaz wants to mention anything about this as well.
Yeah, this is all fairly new, and it's more. I have to say it's more established in the pediatric population, but there's certainly enough data now to strive to perform these tests for adults as well.
So this means that we have to certify the risk of the patient at first. So any rule for the auto transplant in such case?
I don't think we know currently because, again, until we stratify these patients according to genetic risk and then make decisions based on that genetic risk versus chemo alone, auto high-dose therapy, if there's a response, and allo, we're not going to have data to be able to say this. Currently, we treat all these patients as if they're terribly bad disease. They're, bad ALL, they need to go to allo transplant. But is that the right answer in the future? I'm not sure, and I think risk stratification according to genetics will help us blaze that trail in the future.
Yeah.
If we do a second allo, I think his brother or his sister will not be so beneficial because they are young ages, so they may have some genetic elements we don't know about. What do you think about that? Is matched unrelated donor better for him?
In BALL, the Germans believe strongly that actually matched unrelated donor transplants are better than related donor transplants, but I'm not sure if there's any data to suggest that for TALL.
I'm saying that because he's 20 years old and he may have some gene that is inherited. We don't know. So his sister might have the gene as well.
But you don't have any evidence that any of his leukemia, lymphoma, is related to his sister's cells, right? This is, she is healthy and there's no evidence that her cells are causing problems in this way.
Yes, she is healthy and We didn't do genetic testing, but I don't know. Do you think it could be a possibility?
There's a literature for AML in younger patients having in many cases, a strong familial component. In fact, the ASH educational section 2 years ago did a very good review on this and the 30 some odd genes that have now been found within families that predispose to AML. I am not aware of any significant literature in the TALL space for any kind of familial genetic risk. Dr. Gabala, do you know anything about this?
No, absolutely not.
Yeah, same here. I'm not aware of the familial part in here. And in all honesty, I think the second allo is it's not likely going to happen unless this GVHD gets in a better control. We have to get the GVHD in control. We have to control the disease before a second allo. I have to tell you that TLL, typically here we would not use hyper-CVAD in a young patient as a frontline therapy. This patient has achieved CR on third line, but we would definitely be using a CLGB regimen. It's similar to 1043. And sometimes with a TLL specific, using nelarabine upfront in those patients, and comes with it the pigosparaginase and other pediatric inspired regimens. We don't do much peds. Our peds colleagues are the ones who take care of them. So we typically, when we have TLLs and at very young patients, we communicate together to consult with them on that.
Yes, I believe Dr. Hijaz, you are right. In young adults, we typically use the pediatric-inspired protocols unless we are planning allogenic transplant in CR1.
Yeah. Even when we are planning it here, we still take the patient. We use their regimens upfront. Even when we are planning it, we still follow them because they have better success than the adults.
Yes, we have a small study on pediatric inspired versus hyper-CVAD. This study is going to be published soon, inshallah. This study proved that in young adults, the pediatric inspired do much better.
Right.
Yes.
Right.
How can I ask a question? Good evening, everybody. Do you hear me or not?
The voice is very muffled and distant.
You can hear me now?
Yes. Yes.
Yeah. Good evening, everybody. I'm Dr. Noha, Assistant Professor in Adult Hematology. As a salvage option for this patient, what about daratumumab and bortezomib? I have experience with one patient relapsed post-haplo stem cell transplant, and with paraspinal masses. We tried azavan. It was working, but with radiation as well. Without medullary relapse, it was working, but the patient get severe neutropenia and recurrent hospital admission. So then decided to continue in daratumumab with ITs. And he is almost doing well for 1 year. What is regards this as an option for TLL, daratumumab and bortezomib as well?
But Dr. Noha, you are using it to achieve a second CR or just to palliate and extend his survival for some time?
Actually, Dr. Muhammad is not curative. The patient relapsed after Hablo. We are waiting for CAR T cell if it is available for TLL. Still now not established, but as an option to get the patient in sustained remission or response.
But I believe it will not achieve a CR enough to do second transplant.
Is there any CD38, is CD38 positive on this patient?
Yeah,
that we're discussing today?
It was positive, yes. And yeah, this patient already planning to go for CAR T cell for TLL. It is not available, however, there is could be approved as well. in such he is maintained on daratumumab, no medullary relapse, no other extra medullary relapse at time being.
But it is maintained on DARA, Dr. Noha. You achieve TR with DARA or just give it as a maintenance?
With radiation, Dr. Muhammad. He received,
with
he's a patient presented with severe back pain. We did whole spine MRI, showed multiple paraspinal masses. He received radiation and then almost 3 or 4 cycles as a VEN, but it was associated with severe myelosuppression, hypothermia. So he took a break, then continued with daratumumab. Monthly doses with ITs.
So it is a quite similar situation to our patient, Dr. Noha. I think it will be a good option, Dr. Higazi. Do you think it will be a good option for this patient?
So I would like to first see, is the DARA what's helping, or was this achieved by the AZA-VEN and the myelosuppression? Just we stopped everything, and the DARA was more of a maintenance. Was there evidence of disease at the end of the AZA-VEN before starting DARA?
No, you are right. We don't have evidence, but the evidence, that we rely on the patient has aggressive disease. He relapsed after Hablo. So to maintain more than 1 year, almost maybe this is the cause. Like we don't have evidence that he was progressing or has evidence of disease before starting DARA. Yeah.
I honestly, I would like to hear what Dr. Gabala and Dr. Emmons say, because I haven't used DARA in this setting personally. Dr. Gabala, any input from your side on in TLL, the role?
No experience at all with DARA in this setting.
Emmons?
Yeah, I haven't used daratumumab in this setting. And again, we're not, this is obviously something that's usually in our country used more for multiple myeloma. But we're talking about CD30 positivity here?
CD38. CD38.
38, got it, okay. Yeah. And what about CD30? Was this T cell, did it express CD30 at all?
Dr. Noha?
I don't remember actually, no. CD30.
But I believe daratumumab is one of the enlisted regimes in the NCCN guidelines.
In TLL, yeah, it is one of the regimen with bortezomib as well.
One of the approved regimens. Yes, one of the approved regimens was bortezomib.
Yeah. There are regimens that are listed, but like the response rates are unfortunately not that great that we tend to end up using them. But the question here is still, is DARA what's working, or was it the AZA-VEN and the toxicity was the issue? But you're right, the patient has been on it, and you said the patient now is lasting over a year. And I don't know, Dr. Emmons can give not just one lecture, but a week-long talks on CAR-T, T-cell directed CARs that we have experience with here in Louisville. But I don't know if this is going to see the light anytime soon.
Yeah, so, as far as T-cell CAR in the United States, the one that's the most advanced is CD7 target. There's also CD5. Both of them, of course, have languished because of the fratricide, the self-kill of the T-cells in the manufacturing process. That was lesser true for a CD4 CAR, but of course, CD4 CAR makes people functionally HIV as a result. So it's usually the CD4 is being used as a bridge to allotransplant rather than being used post-allotransplant. So CD5 and 7 are potentially promising. There's a CRISPR modified T cell now, which is low expressing CD5, and another one for CD7 that have had better manufacturing prospects for CAR-T usage in the T cell setting. But these are very much experimental questions now, not ready for anything outside clinical trials.
And all these are autologous CAR-Ts or
Correct.
allogeneic?
That's the current situation in this country. Yes, I don't know. Are people like Shimon Slavin doing stuff in Israel or anything in the middle? I'm not sure if what the CAR-T activity is in your neck of the woods. Are there centers that are doing any innovative trials in T-directed CAR?
Yeah, you are asking for the patient I'm talking about?
Right,
Or
like
or
the CAR T for
CAR
T-cell.
T already we are sending medical evaluation in American center. Actually, I don't know which center. Not in Saudi Arabia. Or in Saudi Arabia, only for B cell available. No,
Right.
for T cell till now.
So the centers that are the farthest along in this are places like Baylor, MD Anderson, and Washington University, and then Stanford has a protocol that's fairly far along too with these CRISPR modified T cells for manufacture.
Yeah.
Dr. Gavala, is anybody doing anything at Moffitt?
For T-cell.
No, T cell remains one of these like black boxes because every time we hit it, we also hit the native T cells, which is it's a big problem. So no, we don't have any trials right now.
Yeah. I think we don't know the whole story on the other patient, Dr. Noha, but if the patient is in CR right now with their Velcade, as you mentioned, maybe that's a patient if they're in good performance status overall and is in good shape to with no major organ dysfunction, to consider a second allo transplant for them to avoid the relapse again.
But again, the morbidity and mortality of a second allo transplant or even steroids is so much higher than the consideration of a liver biopsy to direct therapy that certainly seems to me to be the first thing that you'd want to discuss. For this
I'm sorry. This is another patient. This is another patient.
Sorry. Yeah. Okay.
Yes. I 100%. I think between the three, Dr. Gaballa, Dr. Emmons, and myself, the biopsy of the liver of our patient today is maybe the one to consider as the most to advocate for, so we are not, as we are trying to treat, we're not causing any harm right away. I think we took a little over the hour as we promised everybody. And unless there is any questions from the panel or comments from the panel or our attendees, we will conclude today's meeting.
One just quick thing with regard to the first patient, the GVH prophylaxis that was given to this patient was cyclosporin and methotrexate. I'm wondering, it's a related donor transplant, so there are certainly centers that do this, but there are certainly many centers that have also switched to using post-transplant cyclophosphamide in these patients as well. I'm wondering what your consideration there in Egypt is for that now, for related as well as unrelated and haplo donors for that.
For haplo donor, sure, we do post-transplant cycle. But for fully matched sibling donor, centers use some centers use post-cy, but at our center we do not use post-cy. We faced a lot of problems with hemorrhagic cystitis, so we use CSA and methotrexate.
I think with the PU-Cy conditioning, that's for sure a big problem. So this patient got PU-Cy pre-transplant conditioning, so post-Cy might even make it a higher risk.
We moved to Flu-Pu-Mel. We moved to Flu-Pu-Mel.
So Flu-Bu-Mel.
Yeah.
So how much Bu?
4.
So Flu-Bu-4-Mel?
Yeah.
Oh wow. Okay. So we do Flu-Bu-4, Flu-Mel, but Flu-Bu-4-Mel
what does the addition of Mel give you there, since Flu-Bu-4 is already ablative?
Yes, Flu-Bu-4 is already ablative, but we are using a generic oral PU. We are not so convincing that it's working fine, so we added Mel.
Oh, we're still using
because
the
of
oral.
the quality of the drug. You have had. Oh my goodness. Okay. Sorry to hear that.
So are you saying this, you're using Flu-Bu-4, but even though it's Flu-Bu-4, you give the Mel because you're not sure if the Bu4 is...
Yes. Yes, we use FlowBio4, but some of our patients actually didn't go to a deep nadir. يعني the platelet dropped to 50 or 60. Neutrophils dropped to 500, never zero. So we shifted to FlowBio4 MEL.
Where do you get your busulfan from?
It is a generic.
Right, but it's made in China? I mean, where is it coming from?
Yes,
Do you know?
yes, from India.
From India?
Yeah.
I see. Is the relative cost of busulfan so high that you can't get it from a more reliable
It's not available.
producer?
It's not available. It's not available at all.
Oh, I see. So you can't import from the United States, for example.
Yes.
I see. Thank you.
I'm just trying to think of what's the benefit of the busulfan if we don't think it's working enough. So maybe we can like get rid of it and use an ablative regimen that is not busulfan containing. But I think in the past we talked that TBI is not available, right? Total body irradiation.
Yeah, it's not available.
Yeah.
What about the quality of the fludarabine? Is that also from India?
No. It is a perfect fludarabine. It is a brand.
I see.
Yeah. Big
For this
barrier.
patient, I think one thing is missing. I believe we did not do chimerism. It was checked only by karyotyping, and I believe karyotyping is not sensitive enough to comment on chimerism in this patient. So I believe we have also to check the chimerism by a more sensitive technique.
But if it is XX, you don't think it's sensitive?
No, it was tested by karyotyping, I believe, for Amanar. It's not sensitive.
Right.
Yes, but we know
Blood
XX
group
is not
the same.
XY.
Blood group the same also.
I believe conventional karyotyping is not sensitive.
Yeah, we typically would go for the standard would be the PCR testing here to identify all these lineage post-transplant.
Yes, I believe we have to do that.
But again, so to conclude, thank you so much, everyone. Dr. Rafiq, would you like to and Dr. Omanar, would you like to conclude so we don't take much longer from everyone?
Yeah, sure. I mean, actually, I know that we are running out of time. I was asked to give that presentation for the pulmonary GVHD, but if you guys want me to put in a later date, I'm completely fine. I know that we are maybe 30 minutes beyond it, but
Yeah, maybe we should have it as an event of its own that we can have
sure.
Maybe we even do that before Ramadan because we are skipping all the way to April for our next meeting.
That's correct.
So maybe in February we can have that presentation and a discussion to follow. Karim and Dr. Munar, maybe we can look into that as an alternative. So at least today we don't keep everyone tied in longer.
Okay, you say so.
Yes, sure.
Sounds great.
Okay.
Sounds great.
Okay.
Anyone going to a tandem meeting? Anyone from Egypt going to the annual transplant meeting next month? It's in Hawaii, so might be more. A lot more. No, okay.
Maybe next year.
Okay, inshallah, see you next year. All right, thank you so much.
Thank you.
Afwan. Go ahead, Rafiq.
Thank you all for your attendance today, and please have a good day. Bye-bye.
Bye. Salam alaikum.
Okay, السلام عليكم. شكرا.